anesthesia, emergency and trauma. But I would also like to mention that she is responsible for a very important part in our hospital. And she's in charge of the medical gas pipeline, which we all know was so important during the pandemic. I would also call it an area of interest, Charu, for you. So over to you, Dr. Charu.
Good morning. I am Dr. Charu Baba, and today I am going to talk about anesthesia for neonatal surgical emergencies. So this is a list of most of the neonatal surgical emergencies that present to us. The most common being the first one, that is a tracheoesophageal fistula. So today I'll concentrate on the first four with the emphasis on management of tracheoesophageal fistula. Now, initially I'll talk about anesthetic consideration in a neonate. A neonate presents to us with peculiar challenges. In fact, a neonatal anesthesia is almost a subspecialty within the subspecialty of pediatric anesthesia. The reasons for this are that they pose so many challenges in terms of their anatomy. There are a lot of anatomical variations, including the airway, which is so different even from that in an older child or an adult. Their positioning can be very difficult. IV access can be challenging, and administration of regional blocks can be very difficult. There is physiological immaturity of most of the systems, cardiovascular, renal, respiratory, that leads to complications or anesthesia challenges. Temperature regulation is very important and remains a challenge for us. They have poor tolerance of anesthetic drugs, mainly because of an immature blood-brain barrier, also immature renal system. Their fluid therapy has to be carefully guided. You have just had a talk on fluid therapy. Another challenge they pose to us is they have associated congenital anomalies, most of them or a lot of them being cardiac anomalies. For the pre-op evaluation, I cannot emphasize enough on exhaustive history taking. And the person you take the history from has to be very reliable. In our circumstances, most of the time, the mother is not available. It's either an aunt or grandmother or maybe the father, and they're not aware. So you have to insist on getting very accurate history. And in the history, the main things you have to elicit is the gestational age, because there are various challenges associated with preterm premature baby or a term baby. Then the APGAR score at birth or any other significant event at birth. The feeding history, whether the child has been fed, there's passage of urine or stool, whether the patient has been on ventilatory support. All these factors are going to make a difference in the management of the patient. During examination, other than the standard examination of all systems and vitals, we must emphasize on examining the hydration status. This we do by palpating the fontanelles, the capillary refill time, the skin turgor. These things are very important. Also look for any coexisting conditions. Investigations are the important ones: are hematocrit, blood sugar, electrolytes, chest x-ray, and an echo to rule out cardiac diseases. Now, important thing in this is that when we do investigations, we must be fully aware of the normal values in a neonate. After this, we have to take consent from the parent or the guardian, and very important to have a good communication with the surgeon as well as the neonatologist who has perhaps been treating the baby prior to shifting to OT and will look after the baby post-op. I'm going to take some time talking about OT preparation because I feel well prepared is half the battle won and leads to an happy ending. So temperature. Can't emphasize enough. Ensure a warm environment throughout the perioperative period. Your responsibility is not over once the baby leaves the theater. So it should be transported in a warm incubator to the OT and to the post-op. The IV fluid should be warmed. The cleaning solutions should be warmed. Now, everybody doesn't have all amenities, but either one or all of them, if you have radiant warmers, heated mattresses, or warm air circulation system. Now, it's a habit that drugs are usually given to the junior most resident posted in the OT. In case of a neonate, I think it should go to a more senior person. There should be extreme caution and vigilance while loading drugs. This is where most of the errors occur. So how it helps is to have a protocol and a list, and preoperatively you can make a list of the drugs that have to be given for that baby with that body weight, and that list can be hung up on the anesthesia machine, or if you have a board, it can be written on the board. All the dilutions and labeling should be cross-checked. For IV fluids, maximum 2 hours of fluid requirement, that is the protocol in our place, maximum 2 hours fluid requirement should be filled in the burette. Equipment, again, there should be equipment, dedicated cart for neonatal equipment. These includes oral airways, face masks, different sizes of endotracheal tube, all airway equipment, laryngoscope, maybe a CMAC or other video laryngoscopes, number of intravenous cannulas of 24, 26 gauge, intraosseous cannula if you have, presence of arterial and central venous cannulae, infusion sets, and burette sets. I have just put out pictures of the SOPs we have in our center. We have SOPs for our postgraduates, so I've just taken pictures for reference. So this is how we manage our neonatal OT. Equipment list, how we monitor the temperature or maintain the temperature, the fluids, how drugs are loaded. We use only 1 ml, 2 ml, or 5 ml syringes with the master syringes kept aside, and a 2 ml syringe with saline flush is always kept ready. This is the list of drugs, how they are diluted, in which syringes they are diluted, and this is the protocol that is followed for every single case. This list is posted inside the OT itself. This is the drug dosage, which has been taken from a textbook. And we usually write the drug dosing for that baby on a board. If you don't have a board, you can just write it on a paper and hang it on the machine. Monitoring for neonates, essential monitorings, ECG, pulse oximeter, NIBP, capnography, precordial stethoscope, temperature monitoring is essential. This is the two trolleys we have ready in our neonatal OT with varieties of cannulae and suction catheters, splints, and this is our airway cart. As you can see, electrodes have been also, as we don't have pre-made neonatal size electrodes, we have cut the ECG electrodes. These are the neonatal BP cuffs. This is for fixing, and these are various connectors, masks, and laryngoscopes. Now we'll discuss tracheoesophageal fistula. This is the most common neonatal surgical emergency that we face. Incidence is 1:2,500 to 3,000 live births. This is not our literature, this is Western literature. Commonly associated with other anomalies, including vectoral, that is vertebral, anorectal, respiratory, GI, renal. The important thing for us is also that 25 to 30% of these are associated with congenital cardiac anomalies, including VSTs, ASTs, tetralogy of Fallot, PDA, and right-sided aortic arch. So we have to keep a lookout for these. This is the standard classification of tracheoesophageal fistula. A is pure esophageal atresia. The most common is, as you can see, is this, and this is what we see in clinical practice all the time. So you have a blind upper esophageal pouch and a lower esophagus connected to the trachea via a fistula. Antenatally, it can be diagnosed on ultrasound. It's very non-specific findings of polyhydramnios with an absent or small stomach bubble in the baby. Now, this can only keep you raise a flag, but this is not diagnostic. Diagnosis is usually done postnatally when the baby is received and the pediatrician is unable to pass a suction catheter more than 9 to 10 centimeters into the esophagus, and there is excessive salivation. After delivery, the child might choke or get cyanosed on feeding. Baby might present with recurrent, depending on where the baby is born, present with recurrent respiratory infections and intermittent abdominal distension. This is an X-ray showing the the nasogastric tube that is getting folded, and this is the upper pouch. Management is surgical. It is usually a primary repair within 24 to 48 hours of birth, with the ligation of the fistula and approximation of the two esophageal ends. Rarely, when the gap is too wide between the two ends, they do an esophagostomy and a gastrostomy. If the baby is sick, then they take a couple of days to improve the general condition of the baby, and sometimes an emergency gastrostomy may have to be done in case there is too much distension of the stomach. Prognostic classification. What is done in 1962 used the criteria of weight, pneumonia, and associated congenital anomalies to grade into high risk and low risk. By 90s, pneumonia had more or less become less of a concern because diagnosis was made, feeding was, and nursing, the protocols had been set, there was good nursing, and you were seeing less and less incidents of associated pneumonia. So SPITs, including weight less than 1.5 in presence of cardiac anomalies as a high risk. Okamoto in 2009 used weight and cardiac anomalies to stratify the risk. The additional factors, risk factors that are associated with a neonate of TEF is gestation, that is associated with the child is preterm. If there is poor pulmonary compliance or the presence of pneumonia, the child has been fed, aspirated. If there is a large pericardial fistula, or even if the repair is done thoracoscopically. In the preoperative period, to minimize aspiration, the child is nursed with a head up, and aspiration of the blind upper pouch is either done continuously or intermittently. Chest physiotherapy is initiated. Fluid and electrolyte status is optimized. If the child is surgery is delayed due to presence of the baby sick or there's presence of pneumonia, then nasojejunal feeds, institution of nasojejunal feeds may be done. Anesthetic consideration. Those that offer neonate, as we have already discussed, presence of pneumonia, associated cardiac anomalies, and if the baby has been on ventilatory support due to either pneumonia or due to which have led to gastric distension. For general anesthesia, monitoring, in addition to standard monitoring, a precordial stethoscope is placed over the chest. Arterial BP is used only in case of associated congenital heart disease or thoracoscopic repair. Why it is important, monitoring, the emphasis during monitoring is that access, due to positioning of the baby, we may lose access to the pulse oximeter or even ECG electrodes. So you must emphasize that the electrodes are fixed properly, that you can manipulate the pulse oximeter if required. Similarly, you should establish a very good intravenous access, should be on the non-dependent limb. It should be accessible after positioning. This is very important. And second cannula should be set up, should be established as a backup. During induction, our goal remains to maintain oxygen without initiating or establishing gastric distension. To avoid that, intubation can be done either in an awake baby or with using spontaneous ventilation or during controlled ventilation. So for that, induction can be done either via inhalational route or intravenous route. Now it's important that to minimize aspiration and difficulty and prolonged intubation, you should have a quiet and paralyzed baby. Therefore, it's important to, in a spontaneous early breathing baby, there may be some struggle and might lead to regurgitation and aspiration. Therefore, we practice what is called modified rapid sequence intubation in neonates. It's not easy to do a traditional one because sometimes pre-oxygenation can be difficult in a neonate. It is difficult to, the laryngeal cartilages are difficult to palpate, might not be able to locate the cricoid. And if you do press the cricoid, airway manipulation becomes extremely difficult. And therefore, we do a modified rapid sequence intubation using very gentle bag mask ventilation and using lowest possible inspiratory pressures. Induction, you have various drugs. You can use thiopentone or propofol. Propofol, people prefer thiopentone in neonates because propofol may lead to hypotension. Inhalational sevoflurane, halothane. Halothane is not used very much nowadays. For quicker induction, we use sevoflurane. For muscle relaxants, succinylcholine, cisatracurium, atracurium, or rocuronium. All these can be used. Analgesia, when you're using opioid-based, get be fentanyl or remifentanil. Fentanyl, we usually do not use more than 1 microgram per kg per kg. You can maintain anesthesia with relaxants. Sevoflurane or desflurane if you are using ventilators, low flows, opioids, or plus paracetamol. Or you can use regional blocks for post-op and intra-op analgesia in the form of caudal catheters, paravertebral epidural blocks, intercostal nerve blocks. Now, these require a certain amount of practice and skill. So now this is important to learn these skills because emphasis is going towards opioid-free anesthesia. A large number of institutes are now practicing bronchoscopy prior to intubation, and this helps in many ways. It helps to identify the size and location of fistula, and it identifies other problems like tracheomalacia, tracheal stenosis, presence of multiple fistulae. This is a picture of the fistula seen above the carina. This is another fistula, and the carina is here. The biggest challenge in management of a baby of tracheoesophageal fistula is during endotracheal intubation. Therefore, intubation, though the process is routine, the positioning of the tube remains a challenge. Our aim is that the tip of the endotracheal tube should be distal to the fistula and proximal to the carina. If you are proximal to the fistula, there is a chance that you'll ventilate the fistula, leading to loss of ventilation as well as gastric dilatation. If we are endobronchial, then it leads to other problems. So how do we achieve this? The standard technique that was done is we perform an endobronchial intubation, then withdraw just till the point that you can hear bilateral air entry. If there is a pre-existing gastrostomy, it is not often seen these days. You advance the ETT till the gastrostomy tube shows no carbon dioxide. The level of the bevel of the ETT tube should be anterior. This is just so that the fistula can be covered by the posterior bevel of the ETT. If it is a pericarinal fistula, large pericarinal fistula, then you have to initiate one lung ventilation, or the fistula can be obstructed using a Fogarty's catheter. If there is now certain things we have to look towards, very vigilant during our intubation and monitoring. If there is a fall in SpO2 and UTCO2, in all likelihood, we have intubated the fistula. And in that case, it must be a large fistula. If there is a rise in airway pressure with poor compliance, that means gastric distension has occurred due to ventilation via the fistula. Now, how often do we see these problems? It is not very often. And we do a lot of neonatal surgeries in our institute and a lot of TEF. This problem is not very often seen. And why? Because most of the fistulae are very small. And most of the fistula are manageable with normal intubation. They get covered by the endotracheal tube. So when do we have a problem? When the fistula is more than 3 millimeters or it is within 5 millimeters of the carina. That is when it is difficult. And this situation is very rare, that you have a large fistula in a pericarinal region. That is why you don't generally see these problems. Now, I wanted to emphasize on the presence of these two nasogastric tubes. So this is the baby. As you can see, there are two. One is a nasogastric tube, one is an orogastric tube. Now, all surgeons do not do this, but most of the surgeons follow this. This orogastric tube is to identify the fistula once the surgeon does a thoracotomy. They will ask the anesthesiologist to move the catheter and they will locate the fistula. This fistula is used as a stent once the repair is done. And this should be fixed over here once they are past the NG tube through the repair. This is the position of a child. Child lies laterally and with the upper arm usually abducted. Again, this depends on surgeon to surgeon. In our institute itself, we have surgeons who have different demands. Some position the upper arm like this, some extend over the head. This is just to open up this area for thoracotomy. At the same time, warming should continue. Factors favoring post-op ventilation. Before this, I'd like to make a point. During surgery, when they have, we do not use nitrous, so that before ligation of fistula, so that there is minimal gastric distension. And after ligation of fistula, it is very important to do suction so that the blood from the surgery does not block the airway. So the factors that favor post-op ventilation are in a premature neonate, if the child has already aspirated and has been on pre-op ventilation, if there is presence of tracheomalacia, the child is hemodynamically unstable. Thoracotomy is always painful. Thoracoscopic surgery has less pain and can be managed. A long gap fistula, child may have a higher incidence of post-op ventilation. In the post-op period, it's very important to keep the environment warm, continue to give oxygen therapy. Monitoring has to continue with vigilance. Neck position should be slightly flexed so that the repair is not compromised. NG tube care is very important. Like I told you, that tube should be fixed and care of the tube is very important. Analgesia in terms of either multimodal or blocks should be given. Congenital diaphragmatic hernia. This incidence in 1:2,000 to 4,000 live births. Etiology, dual hit theory. What is a dual hit theory? That the primary pathology is pulmonary hypoplasia. That is the primary pathology. This is followed by eventration of abdominal contents into the thoracic cavity. So that is how you have a dual insult or a dual hit. And you see more left-sided hernias than right-sided. Now, this is not really a surgical emergency. In earlier days, this was as the baby was born and diagnosis was done, this child was taken up for surgery. Now it is known that the outcome is better if you optimize such babies and bring them to the theater. So this should be usually done in morning hours. What is the pathophysiology? In the lungs, there is underdeveloped airway, abnormal differentiation of type 2 pneumocytes, and lack of surfactant. There are reduced number of pulmonary arteries per unit volume of lung, and vessels become muscularized. There is abnormal response to vasoactive substances. So all this leads to pulmonary artery hypertension with pulmonary hypoplasia. This is the pathophysiology of a CDH, of a baby with CDH. Pulmonary hypoplasia, presence of pulmonary hypertension with surfactant deficiency leads to increase in pulmonary vascular resistance, thereby increased in right-sided pressures. This leads to right-sided strain and presence of right to left shunt, leading to hypoxia, hypercarbia, and acidosis, which again becomes a vicious cycle and leads to further precipitation of pulmonary hypertension. There are two components. Irreversible is when there is hypoplasia and dysplastic arteries. The reversible component is when there is vasoconstriction of the vessel. So when does vasoconstriction occur? Hypoxia, in a situation of hypoxia, hypercarbia, and acidosis. So this is something that has to be strictly avoided in these children. Prenatal diagnosis can be done during an antenatal ultrasound or a fetal MRI. Prenatal management There have been studies of injection of surfactant and corticosteroids for development of the fetal lung. They have shown the results have been equivocal. There is now fetal surgeries. Studies are going on. There are still current studies going on when the fetal surgery, when they obliterate the lumen of the fetal trachea, and as a result of that, fluid collects and leading to lung distension. This is showing some promise, but outcome not clear. Prognostic indicators in the antenatal period. If there is early diagnosis, the diagnosis done at an early gestational age, and there is liver herniation, this is a very poor indication of very poor prognosis. Postnatally, a large defect, cardiac anomalies, presence of severe pulmonary hypertension, low birth weight, or a low APGAR at 5 minutes, indicators of poor prognosis. The clinical presentation of these babies, they come in respiratory distress. They have a scaphoid abdomen with a bulging chest. On findings, there is decreased breath sounds on the affected side, displaced heart sound, bowel sound in chest, and presence of hypoxia. The diagnosis is confirmed by a chest X-ray. Postnatal optimization. These children are put on mechanical ventilation, may need ventilation, and when you are put on ventilation, they must ensure that the peak inspiratory pressure is less than 25 centimeters of water. FiO2 should be minimum to achieve a SpO2 of 85%. PEEP should be kept for 3 to 5 centimeters of water, and permissive hypercapnia is allowed. High frequency oscillatory ventilation, nitric oxide, ECMO, and pulmonary vasodilators. They are all done to dilate the pulmonary vasculature, thereby decreasing the right ventricular strain and improving the oxygenation. These are all showing equivocal findings. ECMO is usually done in very sick children, and there are criteria in which children need ECMO and definite contraindications to ECMO. This is mainly useful in very, very sick children. Pulmonary vasodilators like prostaglandin, sulfentanyl can be used, prostacyclins. Even other drugs like neuromuscular blocking agents are used to synchronize the ventilation and decrease the VQ mismatch and thereby increase oxygenation. All these maneuvers are done postnatally to optimize the patient. And this is our aim. The timing of surgery should be once we have achieved these parameters. The MAP, or the mean arterial pressure, should be normal for gestation. The preductal SpO2 should be 85 to 90% on an FiO2 of 0.5. Lactate should be less than 3 millimoles per liter, and at least 1 milliliter per kg per minute of urine output should be there. That is when the baby is considered optimized and to be taken up for surgery. Treatment is surgical, where you have to return the gut contents and close the defect. It can be a primary repair, or a patch can be applied. It can be done via open thoracotomy or via a thoracoscopic procedure. Anesthetic concerns, other than the neonatal concerns, are in these babies you have decreased pulmonary reserve. There is presence of pulmonary hypertension leading to right to left shunt, hypoxia, hypercarbia, acidosis, has been discussed, risk of barotrauma, and presence of associated congenital anomalies. Even in these babies, you have 20 to 30% chance of coincidental congenital anomalies. In the pre-op preparation, there should be insertion of a nasogastric tube that drains the bowel contents, and intravenous line in the upper limb. As when we close, if they surgically remove the gut contents from the thoracic cavity and put them into the abdominal cavity, there might be an increase in the intra-abdominal pressures. Optimize the pulmonary hypertension. Arterial cannulation may be needed in a compromised child, or if there is presence of congenital heart disease. And preductal as well as postductal SpO2 should be monitored. And during general anesthesia, baby is pre-oxygenated. Induction can be either by the inhalational or intravenous route. A modified rapid sequence intubation, as discussed earlier, using a gentle band mask ventilation. Even in these children, nitrous oxide is avoided. FiO2 should be kept to target an SpO2 of in and around 95%, a PaCO2 of 25 to 30%. It is good to use, nowadays cuffed endotracheal tubes are used to minimize aspiration, microcuff endotracheal tubes in small children. Maintain on oxygen, air, opioids, inhalation. Again, opioid-free anesthesia can be used when you can use either epidurals, caudal catheters. In the post-operative period, we will discuss the children who can be extubation later stage. They may need post-op ventilation. Analgesia should be continued. Patient should be warmed and fluid status should be optimized. Omphalocele and gastrochisis. What is the difference in the two? In omphalocele, the contents are covered by membranous covering, while a gastrochisis, the herniated bowel is exposed. This gastrochisis has very less occurrence with other anomalies, while in omphalocele you have associated congenital anomalies. Antenatal diagnosis is usually by the use of ultrasound. In omphalocele, the elective surgery, cesarean is usually done at term. In this case, because the bowel is safe, covered by a membrane. Gastrochisis benefit from early delivery as the bowel is exposed. The preoperative management, fluid resuscitation is very important as a lot of fluid and temperature loss occurs due to the exposed bowel. Care of the herniated contents, they are covered by a silastic. In our setup, they usually use Eurobag and cover the contents. Either way, the bowel should be safe and it should be a smooth structure so it doesn't harm the bowel, as well as there should be no fluid loss or temperature loss. Nasogastric tube is used for decompression and temperature of the baby has to be regulated. Surgery for omphalocele, usually an elective procedure unless membranes rupture. Small defect can be done in a single stage. Last defect, they put a silastic pouch with gradual reduction. Gastrochisis, repair is usually done within hours of birth. The bowel is compromised, therefore it's an emergent surgery. It is again either primary or a stage procedure. Anesthesia, a lot of emphasis on fluid therapy and temperature regulation, as has been discussed. Nitrous oxide is avoided to prevent bowel distension. Analgesia can be either by caudal or opioids, use of IV fentanyl. Now, once the thoracic abdominal contents have been removed from the thoracic cavity, now the surgeon and the anesthesiologist have to have very good communication at this stage. Because if they close the abdomen under high pressure, it can lead to respiratory compromise. Other than respiratory compromise, it can also compress the IVC, lead to fall in blood pressure, as well as the renal circulation and lower limb circulation. So it has to be very clear communication between the surgeon and the anesthesiologist, whether they can close the abdomen or have to do it in stages. Infantile hypertrophic pyloric stenosis. Earlier on, it was simply called pyloric stenosis. This is hypertrophy of the smooth muscle of pylorus, usually present in the second and third month of life. Now, there is a study in UK where they have indicated that these children are presenting earlier, and that is because of ultrasound findings. This diagnosis is done by ultrasound, and the children usually present with a projectile, non-bilious vomiting, and failure to gain weight. The contents of this bilious vomiting are usually acidic with potassium, so the babies end up with hypokalemic, hypochloremic, metabolic alkalosis. This vomiting leads to dehydration, fall in plasma volume. So this leads to a secretion of aldosterone, which causes sodium and water retention, leading to further potassium loss in the urine and worsening the hypokalemia. And This is to the sodium and water retention leads to maintenance of plasma volume. This is the pathophysiology behind pyloric stenosis. Now, this metabolic alkalosis, the medullary chemoreceptors respond to this. Medullary chemoreceptors lead to increase in respiration when there is an increase in H ions in the CSF. When there is, and the reverse happens during metabolic alkalosis. So the decrease in H ions in CSF lead to respiratory depression and apnea. Now, therefore, it is very important to correct metabolic alkalosis before surgery. Now, this metabolic alkalosis can be corrected in the plasma very quickly, but it takes time to equate in the CSF. Therefore, even intraoperatively, though you may have corrected the metabolic alkalosis, we have to continue to monitor for apnea in the post-operative period. Therefore, optimize fluid, electrolyte, and metabolic alkalosis prior to surgery. It is actually, IHPS is considered a medical emergency more than a surgical emergency. In anesthesia, it is very important to monitor the fluid chart, what the baby has received, and how much fluid is ongoing, what kind of fluid is ongoing, because it is very important to replace the potassium also in these children. Nasogastric tube should be done. Nasogastric aspiration is done in most centers. There are certain centers that do not practice NG tube aspiration prior to anesthesia. Ultrasound assessment of gastric volume status can give a good idea about how much volume there is in the stomach. A modified rapid sequence induction intubation should be done. Use of microcuff endotracheal tubes are important in preventing aspiration. Avoid the use of nitrous oxide. Post-op anesthesia can be used again with epidurals and caudal catheters. Now, whether we should extubate the babies, the neonates on the table or not. Now, this is always a challenging question. Should we or not? Should we or should we not? Now, why is it so challenging? The neonates have a very high consumption of oxygen. Their BMR is very high. In addition, they have low storage of oxygen in terms of they have low FRC. Their tidal ventilation falls within the closing volume, leading to atelectasis, and they have an immature respiratory control mechanism. Therefore, their oxygen consumption high and the reservoir less. Pharmacologically, they have an immature respiratory center. The blood-brain barrier is not developed, and in the renal tubular functions are impaired, leading to sensitivity to opioids and other anesthetic drugs. The patient factors that contribute towards the conundrum of extubation is they might be preterm, they may be having associated congenital anomalies, also depends on the type of surgery. Now, another contributing factor is infrastructure of the institution. Do you have an intensive care setup? Do you have adequate trained manpower to deal with neonates? Do you have ventilators? Therefore, all these factors contribute towards the decision-making of extubation for neonates. Now, when do you extubate? When the baby achieves a normal hemodynamic status. The child's temperature is normal. The baby has regular respiration with adequate tidal volume. The child is moving the upper limbs, flexing lower limbs. There's eye opening and grimace. This is when it is safe to extubate the neonate. Key takeaway points is we have to understand the physiology and pharmacology, I would add anatomy over here, of term ex-premature and premature neonates. Exhaustive history and clinical examination is mandatory. Interdisciplinary communication should be there. Operation theatre preparation is half the battle won. Vigilance with emphasis on vigilance during drug preparation. There should be intense monitoring throughout the perioperative period. Understand the extubation challenge as well as post-operative monitoring. These are some of the questions that have come in the last 10 years. I have not repeated the question, but there is a question on oxygen therapy neonates, a pre-op management of pre-op management of a 2-day neonate with CDH, pre-op evaluation, anesthetic management of a neonate with TEF, concerns and anesthetic management of neonate for CDH repair, fetal circulation diagram, discuss anesthetic consideration of various surgical emergencies in neonates, 1-day baby with respiratory distress scheduled for TEF, perioperative anesthetic considerations, including pre-op optimization and preparation, anesthetic management of neonate with pyloric stenosis for emergency surgical repair. I think we have discussed most of this other than fetal circulation diagram. Thank you.
So thank you, Charu, for a very nice lecture. It clearly highlighted all the issues of the major neonatal emergencies that we have. And again, I would like to ask whether there are any questions that the students have.
No, ma'am, no questions from the delegates. Yeah.
Okay, so I think then we can end the session there. I was just going to conclude.
Ma'am, can I put in a word, ma'am?
Yeah, sure.
I'd like to appreciate the lecture by Dr. Dias.
Yeah.
I think it was a great lecture on IV fluids.
Yeah,
very comprehensive and very good.
Very good. Same with you, Charu. I think you also done a very good job.
Thank you.
And I think the good thing was that you paid the emphasis on OT preparation. That is very important because people just go theoretically and they start off with it. But even in exam and even otherwise, students should talk about it. I think it's very important. And also when you do neonatal surgery, another thing which you said already is that the backup is very important. You should have a neonatologist in your hospital. You should have a NICU or a PICU because pre and post-op care is equally important as the anesthetic care is. So I would like to thank the organizers to invite me, and whether Charu wants to say something, she can also say.
Yeah, that's it, ma'am. Thank you.
Thank you so much. Thank you.
Thank you, ma'am. Thank you so much for being a part of APPEC2023, and thank you for both the presenters and wonderfully presented and in a very lucid way. Thank you so much.
Thank you.
So we'll run quickly through the questions of the first quiz. So the first question, here it goes. Regarding perioperative IV fluids in children, all of the following are true except option A, 0.9% saline is isotonic, but large volumes can cause suppression of renal blood flow and hyperchloremic metabolic acidosis. Option B, the maintenance requirement for a 3-day-old 3 kg neonate is 80 to 100 ml per kg per day. Option C, the stress of surgery causes a rise in the ADH levels. Hence, rapid infusion of hypertonic fluids is advocated post-operatively. And last option, that is option D, neonates less than 48 hours old, children below the 3rd percentile in weight, infant of diabetic mothers are at high risk for hypoglycemia and should receive dextrose maintenance solutions without prolonged interruptions. So you need to go for the exception, which is not true, right? Coming to the question 2, the dose of oral midazolam for pre-medication in children. Option A, 0.1 to 0.2 milligrams per kg. Option B, 0.5 to 0.75 milligrams per kg. Option C is 2 to 3 milligrams per kg. And option D, 3 to 5 milligrams per kg. So we'll take a 5 minutes tea break. We'll be back by 10:15 to resume our session of long case discussion on a pregnant female with mitral stenosis. The session will commence at 10:15, 15, not 50. So just keep a note on that. Thank you. Welcome. Welcome back. Now we'll move on to our next session, which is a long case presentation of a 38 weeks pregnant patient with mitral stenosis posted for elective LSCS. And for this, we have a very seasoned examiner, Dr. Sujata Chaudhary. Ma'am is Director Professor at Department of Anesthesia and Critical Care and Pain Medicine at Guru Tegh Bahadur at Safdarjung Hospital, New Delhi. I think there's some correction needs to be done. Ma'am's area of interest are airway, resuscitation, trauma, OPS anesthesia, and regional anesthesia. And she has several achievements to her credit. She has been in charge of advanced skill lab, has conducted BLS and ACLS courses, has been a reviewer for various journals and examiner for MD and DA exams in various universities. And she has more than 60 publications in various national and international journals to her credit. We welcome you, ma'am. Moderating this session, we have Dr. Sangeeta Yadav. Ma'am is Associate Professor at ABVMS